Never occurred to me. Of course, I don't have much of imagination, so. Here's UV. Anyway, so we'll be right back here. Oh, there. All right. Okay, so here's lymph node. So stuff comes in, lymph, not stuff, interstitial fluid, lymph, comes into the node through the afferent vessel, afferent. So you see you got a bunch of afferents coming in. They're bringing us into the tissues. Think of like this is just like a sandbox that stuff's going to percolate through, like coffee grounds that water percolates through. So the lymph comes in through here. It's inspected by the T cells and B cells, which are in here, and then it exits through a single efferent. So maybe you can remember efferent and exit. Okay, so it comes in, it's inspected, and exits this way. Now I've got a couple of questions about this little structure called the hilum. This is just this sort of little indentation here. It looks like a little bean. This little indentation on the side where the little artery, little vein, and the efferent vessel exit. It's the hilum. Also, you can see another term on here. I could probably show this on the slide. But this has an outer cortex, and there's little fingers of cortex which kind of migrate into the structure of the lymph node, and they are called, I know it's on here someplace, oh, right here, called trabeculae, kind of like a trabeculae carne of the heart, although not the same. There's little fingers of the capsule that kind of separates the node into little compartments. And it's full of these little things called germinal centers where you find the T cells and B cells. And so if something's coming in here that's got a bad infective agent in it or something, this little node's going to get swollen. So those are lymph nodes. And you got thousands of them in the body. That's why it looks like under a microscope. So this would be the outer capsule out here. These areas called the germinal centers. This is just the center of the lymph node. Oh, okay, now let's just look at a couple of pictures of some of the representative lymph nodes. These are the ones that are real common in medicine. The cervical nodes, the ones up here, the ones that you can really feel, right? The neck. The other important ones are the ones here, axillary region. There's major drainage through there, the axillary nodes. There. By the way, these are also shown on our mannequins back there. Have lymph nodes on them. Some important ones, especially for breast cancer and things like that, are the lymph nodes which are associated with breast tissue, because as you're you're probably aware of this, in a case of, say, a lumpectomy or a mass which is removed, a cancerous mass which is removed from breast tissue, not only do they remove the lump, of course, or the cancerous tissue, but often the surgeons will take out some of the associated lymph nodes just to see and send them off to pathology to make sure that there's no evidence of cancer cells in the lymph nodes. Because if there's the potential of cancer cells in the lymph nodes, that then gives the potential for the cancer to have spread throughout the body. Metastasis is the word you're familiar with. So when the report comes back from pathology that the nodes are clean, in other words, no evidence of cancer cells in there, that's a good prognosis, a better prognosis, because if there is evidence of cancer cells in the nodes, then perhaps more aggressive therapy might have to be done in terms of eliminating cancer from the body. So these are really important sort of sentinel nodes here in cases of breast cancer. And the last one, of course, are the nodes down in the inguinal region, down here in the groin area, and those are important inspection nodes as well for disease and things like that, or infective materials going on. And lastly, our last big organ here is the spleen. Of course, you know about the spleen. It's a very soft, pulpy organ, kind of right here in your back, your left side. It's made of, and I used to do stuff with spleens. It's made of a lot of lymphocytes, and when you look at it, it's divided into things called red pulp and white pulp. You can hold it. I don't know, it's about this big. It's kind of mushy, and when you look at it, it's just kind of red and mushy, and it's real bloody. because it's got a really rich blood supply to it. And the red pulp are mostly red blood cells because one of the primary jobs of the spleen is to take out old red blood cells. Red blood cells only last about 120 days, so it takes out old red blood cells. And also, it has white pulp, which are actually the spleen nodules, because the spleen has a very rich blood supply coming to it, so it can inspect the blood and stuff like that for various pathogens. On a slide, it really doesn't look red and white, but I'll show it to you later. And that's what the spleen looks like. It kind of looks like, it sort of looks like this. You see the red pulp here, and these little bigger, sort of darker nodules. They're not white, are they? But this is the white pulp, this is the spleen nodules. So spleens are a very pulpy kind of, if you rupture your spleen, you can't really sew it up, so you just take it out. And you're okay without it. The liver takes over, kind of removing old red blood cells. Maybe you would be a little bit more prone to infection without a spleen, but you can live without a spleen. I was going to call it an apprenticeship, but I did 1 year of work in an immunology lab, a surgical immunology lab. We used to get spleens from accident victims, and we used them to make antibodies to help kidney transplant patients not reject their kidneys. This is the days before the drugs like cyclosporin, and acute rejection was difficult to control. So we would occasionally get a spleen down in the lab, and me and this other guy were the antibody makers. I don't know how I got this job, but we would take the spleen and grind it up, literally grind it up in a blender, and through some simple procedures, isolate lymphocytes, which are white blood cells, right? And then we take the lymphocytes across the street to the quote-unquote farm, which wasn't really a farm, where we had goats. And the goats were usually not happy to see us because they knew they were in for trouble. We would inject the goats with human lymphocytes, and then the goat's immune system would make antibodies against human lymphocytes because human lymphocytes are foreign to a goat. And then a couple weeks later, we would come back, again, the goats would not be happy to see us because now they were going to donate some blood. We didn't kill them, okay? We just took out a unit of blood and it purified antibodies from that. And then if a person went into acute rejection, the antibodies were sterilized, of course, and they would get these anti-lymphocyte coagulant antibodies that he and this other guy made to keep their kidneys from being rejected. So, maybe I did something. I injected goats, but they had horns. They were never happy to see us. They come after us. It took 2 people to do it because one guy had to go. I was a goat wrangler. It's on my resume, by the way, goat wrangler. And grab the goats and sort of hold them in the corner and give them their shot or bleed them. It was an icky job, but had its benefits. That's what the spleen looks like. So I saved kidneys, maybe. So another picture. See where it is. So that is pretty much the lymphatic system. How about that?